Good evening, and welcome to the Omega Psi Phi Fraternity Incorporated Second District Health and Wellness monthly webinar. I would like to welcome all of you here, and in the native Twi language, Akwaba, which means welcome. I want to say first off that the information presented here is for informational purposes, and the opinions by the presenters do not necessarily represent those of the Omega Psi Phi Fraternity Incorporated. As usual, each month we try to prevent some type of prevention or health topic with prevention based on diseases that primarily affect and impact communities of color. So without further ado, I'm going to have Dr. Jedan Phillips, 88 as we call him, come on and introduce himself as he is the chairman of our Health and Wellness Committee. Dr. Phillips.
Hey, 78, how are you doing, my brother?
I'm great, my brother.
Hey, I think this month is extremely important, as we, and you and I know this very well in dealing with COVID. One of the things that was taking lives and causing, problems during that pandemic was also heart disease. Many patients, people that were on blood pressure medicines, they were interrupted and weren't able to get their medicines. And now we have to deal with the fallout from that. So I think, again, we've all seen people that have suffered from heart disease itself or other byproducts of heart disease. And it's important for us to really recognize what the important preventive information is so that we can prevent those things from happening to us and be there for our families. So again, good to see you, my brother. Looking forward to this conversation. And I'm looking forward to the brothers joining us.
Thank you so much, Dr. Phillips. Now I'd like to take this opportunity to ask Dr. Wingfield, 92 as we call him, a cardiologist, come on and introduce himself and give his opening remarks.
Hi, good evening. Welcome, everyone. It is, as always, an honor, pleasure, a privilege to be here tonight to speak about something that's very near and dear to myself, as well as the other brothers on this call. I am an interventional cardiologist. I practice cardiology in Hamilton, New Jersey. Heart disease directly impacted my family, as most all of us have been impacted by heart disease. We're all aware that every 34 seconds, someone suffers a heart attack, and every 84 seconds, someone dies of a heart attack. Anytime we discuss heart attacks, we discuss stroke. Every 40 seconds, someone suffers a stroke. And every 3 minutes and 14 seconds, someone dies from a stroke. So these are two conditions that impact us. But more broadly speaking, tonight we will talk about heart disease, cardiovascular disease in the entire spectrum, so that you can not only learn about heart disease, stratify yourself, understand what your risk of heart disease is, but also to make changes in your life to really let this talk in our discussion really move the needle to empower you to take control of your heart and your health, as well as your family. So it's a pleasure to be here. Thank you. Let's get going.
Thank you. Thank you so much. Dr. Isabell, why don't you give us your opening remarks, please, sir?
Good evening. Apologize for the rain. It's pouring outside. Dr. Lee Isabell, board certified internal medicine, and I'd like to give you my perspective on hypertension, heart disease that has one of the number one cause of death in the United States, and preventive measures, my perspective from primary care. Thank you.
Thank you, Dr. Isabell. Dr. Plummer, our women health and OBGYN, Dr. Plummer. Would you give us your opening remarks, please?
Hi, good evening. Glad to be with the brothers again. My name is Dr. Christopher Plummer. I'm board certified in OBGYN and also maternal fetal medicine. I specialize in high-risk pregnancy. I'd like to have a discussion with you all today about the number one killer in women, which is heart disease, and the reason why it also goes unrecognized. And we'll have a great, lively discussion tonight.
Thank you, Dr. Plummer. And last, but certainly not least, Dr. Ford, would you give us your opening remarks?
Good evening, everybody. Just want to say thanks for having me. My name is Dr. Kelvin Ford, and I'm a board-certified internal medicine physician practicing in Prince George's County, Maryland. As everyone's already mentioned, heart disease is the number one killer. Being a primary care physician, we're about trying to help prevent those cardiovascular diseases from occurring. And so we'll talk more about that this evening on how we can do some of those things.
Thank you so much. And as many of you may recall, I am a retired pediatrician, also trained in internal medicine. So just because I practiced pediatrics for the last 22 years before retiring, well, 22 years plus now, I've been retired almost 4 years, we still saw heart disease in the pediatric population as well. So it does not escape, and it has no respect for any age groups. I'm sure Dr. Wingfield will tell us a little bit more about that, because I'm sure he's seeing more and more younger people with heart problems. And certainly in my specialty, a lot of children were impacted by COVID with during COVID and post-COVID with cardiac disease. So hopefully we'll be able to talk a little bit about that as well tonight. But before we get into anything different, I'm just going to go ahead and turn it over to Dr. Wingfield to give his opening remarks. Doctor, what is the big deal about heart disease? Why are we having a whole month dedicated to heart disease? Why is our community, why do they need to know about heart disease? What is the big push right now? Go ahead, Dr. Wingfield.
Right. Thank you. Yeah. Heart disease. I mean, when we look back at the history, we all are aware that it is the #1 killer in the United States as well as throughout the world. Since we've been tracking the data in terms of heart disease since 1900, heart disease has been the #1 cause of death in the United States. And we always say, except for 1914, when it was the Spanish flu. We all lived through and made it through COVID. And we talked about the astounding numbers of lives lost during COVID. But even with COVID, heart disease remained #1 in terms of killer amongst men and women. It is really untreated, undetected in a lot of cases. The presentation can be baffling in some scenarios and can be missed by healthcare providers as well as patients. So education is extremely important. And we have seen the trend in terms of heart disease therapies increase. And that's what we're trying to do here tonight. So heart disease, it is a huge spectrum, and interested in kind of giving a thorough presentation on that disease process.
So, we talk about heart disease, but heart disease encompasses many systems in the body. I mean, you talk about, people don't realize high blood pressure is a part of the cardiovascular system as well as the renal system in the body. So what are some of the major categories of disease, the major categories that we see that fall under the category, group of heart disease in our community and communities of color? What are some of the things we see on a routine basis, particularly primary care people that come to you first with their first complaints? And I'm sure, Dr. Plummer, you tell us about women, because most women use you as their primary care in a lot of cases. So what are some of the diseases that we see that fall into the category of heart disease that people don't realize are related to heart disease? Anybody can take that question.
Dr. Phillips.
I think one of the biggest ones that we see is the relationship with kidney disease. Again, one of the biggest triggers for end-stage renal disease, contributing to the need for dialysis and kidney transplant. And a major part of that pathophysiology is the uncontrolled blood pressure. So again, that's one place. I'll yield to my brothers.
Dr. Isabell, you started to say something. Did you have something you wanted to say?
Yeah. What contributing factors to heart disease? Diabetes is one of the main contributing factors. Even if your diabetes is well controlled, you're still at a higher risk. So you still should get evaluated, check, see a cardiologist. Mm-hmm. Smoking is a risk factor for heart disease. I'm also seeing less other common risk, but which is common also marijuana, as in states it's becoming more legalized, recreational, and they're finding out that marijuana, smoking it now, if you're older or smoking every single day, it can also now increase your chances of heart disease and a stroke. And so that's not safe always just to do marijuana. Like we found years ago, smoking's not safe, and also large amount of alcohol consumption. These are some of the things, as well as certain, you see certain medications, steroids, and other things like the use of Adderall, things that are common that can put a strain on the heart, cause arrhythmias. And we've noticed that has gone up a lot. The use of COVID, more people are using these medications.
Wow. So, Dr. Ford, what do you see in your office every day that you think people need to be aware of? I mean, I'm sure you have a lot of people coming to you that are not even aware that you have some type of heart disease. What are some of your things that you're seeing?
Well, another big risk factor is cholesterol.
Oh, yes.
Right. And so, trying to control your cholesterol. We know cholesterol clogs up arteries, right? And so that's a risk factor for having coronary artery disease, which is strokes, peripheral vascular disease. So that's a big thing that we have to try to get under good control. And I know, everyone should really try to figure out what your cholesterol parameters are. But then there's also some other cholesterol parameters that I know, brother Dr. Wingfield will probably get into a little bit later. Was it little a, lipoprotein little a, and so those are some of the things we need to really focus in on, because it's about how we're eating, right? Basically, cholesterol, we have to try to avoid a lot of fried foods, avoid processed foods, a lot of butter, egg yolks. So those are some of the things we need to do, is try to decrease that cholesterol, and also exercise.
So I know we're probably going to talk about this a little bit later on, but are there any genetic problems that cause it to have cholesterol? Any family history things that we need to worry about? I for example, I often saw kids that had high cholesterol as young as 12 and 13 years of age. And, it wasn't a simple idea of telling them to go watch their diet, because they may have some type of congenital anomaly or congenital defects associated with it. So something else to think about in terms of cholesterol there as well. So if your family history of cholesterol in your family, you want to make sure you take a look at your children, your adolescent boys, and especially those that are going to be playing sports and things like that. So, but on a more specific level, let's talk about heart disease in women. I heard you say Dr. Plummer is the #1 killer in women. How so?
Well, from what I'm seeing in my office and in my practice, a lot of women don't really get a lot of primary care. So the first time they really get an exposure to the doctor is when they are pregnant. So some of them have underlying heart disease and high blood pressure by the time they already come to the office. And unfortunately, a lot of other people go to the doctors, they go to the ophthalmologist, and they don't take their blood pressure. So the only time they usually get their blood pressure taken is either if they go to their primary care doctor office, the emergency room, or when they come for their OB visit. And dealing with a person that already has high blood pressure, that puts them in increased risk for them developing preeclampsia. And preeclampsia is elevated blood pressure and also protein in the urine, which can also affect their liver, can also cause seizures. And the only cure for that is also delivery, which might be very, very premature. So the most ideal situation is to have a patient come in with controlled blood pressure on blood pressure medication, have check their kidneys with a 24-hour urine, and then follow the pregnancy a lot closer, and make sure that they are compliant with their blood pressure medication. Also, after having preeclampsia, even if you didn't have heart disease before, you are at increased risk of developing heart disease or high blood pressure and issues later on. So if after pregnancy and you have a history of preeclampsia, you should be followed by a primary care doctor at least yearly.
Do women have the same symptoms, the same presentation, and say heart attacks?
Oh no, they are. It's very vague. Sometimes they come with jaw pain. Sometimes they might come with arm pain. Sometimes they might come with just indigestion, nausea, vomiting. Those are the presentations that they can have for for a heart attack. It's not like you would see on Sanford and Son, somebody grabbing their chest and just saying, "I'm coming. I'm dying here of a heart attack." It's very, very subtle. That's why sometimes it's missed if you don't really pick up on it. And even having a heart attack, and even in pregnant women, although it's not as common, it can happen. And those are also things that we also have to look out for.
Thank you so much. We talked so much about so far, a lot about hypertension, but Dr. Wingfield, I'm sure there are other things you want to talk about. The biggest thing I see right now in the maybe in the media world or whatever, you got all these Apple watches, you got these other watches talking about rhythm problems. Can you give us a little bit of background on one of the biggest problems we see, and what is the biggest rhythm problem we might see in heart disease?
Yeah, I think that's a great question. Especially when we talk about these smart devices and apps that we have. One thing, and I'm going to come back to that question, that we do from a cardiology standpoint when you see your cardiologist is we're going to assess your risk, okay, your risk for heart disease over the next 10 years, right? So we're going to sit you down. We're going to take a look at the risk factors that we've all discussed and determine what is your 10-year risk of having an event. Are you low risk, borderline, high risk, intermediate risk? And what we do is we take a look at those numbers. One, what's your blood pressure? What's your systolic blood pressure? What is your cholesterol? What is your good? What is your bad cholesterol? Are you a smoker, male or female? And we plug in those numbers, and it's going to give us your risk. So I'm sure we could drop a link at some point, but it's their apps, their CV risk calculator or cardiovascular risk calculators that you can use, you can download to really see where you are. Are you a smoker with diabetes? Do you take medications for blood pressure or not? So all of those factor into a true and tested way of determining what your risk of heart disease is so that you can begin to act on it. And when we talk about these smart devices, we talk about detecting rhythm issues. They can monitor your heart rate, and they can also monitor your blood pressure in a lot of scenarios. But in terms of the most common rhythm abnormality that we start to see, especially as we age, is atrial fibrillation. Okay, and atrial fibrillation is a condition where the top chamber of the heart begins to beat irregularly. And this can drive the overall heart rate to be very fast. You can present to the emergency room with a heart rate of 170, 180 beats per minute, when an average heart rate is 72, 80 beats per minute. So your heart is beating extremely fast. And this can cause symptoms, lightheadedness, dizziness. You can pass out. But the thing that we're most concerned about, one, is controlling that heart rhythm, because if that heart rhythm goes undetected for days and weeks and months, it can begin to weaken the heart, and you can develop a cardiomyopathy, okay, meaning that the heart muscle is weak and it's not squeezing effectively. And this is driven by the heart going at a high rate for a long period of time. In addition, when we talk about atrial fibrillation, it's the tendency to develop blood clots in the heart. Okay, so while the heart is fibrillating or quivering, we call it, blood clots can develop in the atrium. Those blood clots can dislodge and travel to the brain, causing irreversible stroke. So atrial fibrillation is not a benign thing. And a lot of the drivers for atrial fibrillation is hypertension. So we can discuss hypertension at length, because every condition, hypertension is the fuel to the fire for everything we mentioned, whether it's diabetes, high cholesterol, whether it's stroke, heart attack, AFib, sleep apnea. Hypertension is intertwined in there. So certainly more attention we can give to high blood pressure.
You mentioned sleep apnea. I remember in our pre discussions, we talked about, I think it was Dr. Isabell had mentioned something about getting sleep studies for new onset atrial fibrillation. I think that's something that we don't know as community people, lay people, that we need to think about getting some sleep studies done. Any comments on that, anybody?
I think sleep apnea has always been something that was a source of humor. I think when you look at just the portrayal of snoring historically on film, it's never done with thinking it's anything serious other than somebody who's very tired. And like you said, There are many conditions that are associated with sleep apnea, and it is very, very serious. So, I think it's important to, number one, as a provider, I try to ask other questions, like, do you feel tired during the day? Like, I have some patients tell me, one guy used to tell me all the time, when I'm driving home from work, he'd work from 6 to 2, he'd have to pull over because he said he would fall asleep all the time. And he said he never felt that his sleep, he felt well rested. So, and then he was exercising or trying to eating right, but still could never really lose weight. And it just was, and then you look in his mouth and he has the anatomy that's very suspicious of sleep apnea. And I remember when he first got his machine, after they diagnosed him with severe sleep apnea, saying that he stops breathing about 100 times an hour while he's sleeping.
Wow.
He came in, felt like somebody injected him with adrenaline, because he said, I've never felt this rejuvenated in years. But it is a major, major problem, and definitely, as they say, causes stress on the lungs, but most importantly, for the point of our conversation, the heart as well.
So you mentioned a very interesting thing. I think we often forget, because we don't like to talk about this in our society, is weight or being overweight. So somebody tell me about the impact of weight on the heart. Anybody want to take that question for me?
Yeah, let me just say, just to kind of take that from the sleep apnea standpoint. In terms of sleep apnea, obviously we understand that is when your airway closes while you're asleep. Okay, so it's obstructive sleep apnea. So the airway is compromised, and while the airway is compromised, you essentially are not breathing. Okay, and your brain realizes that you're not breathing, so it actually wakes you up. In the process of waking you up, there's adrenaline surge. We talk about adrenaline, but throughout the night, you're getting pounded and pounded with these surges of adrenaline. And by the next day, your blood pressure is ramped up. So sleep apnea triggers hypertension. And obesity is one of the big factors, especially, throughout the world. If we look at the portions that we eat now compared to 20, 30, 50 years ago, our diet is completely upside down. From you go to any 7-Eleven or McDonald's, everything is supersized or big gulp or something along those lines. So we're eating poorly, and as a reflection, obesity filters in. Now, the problem with obesity is typically uncontrolled blood sugars, hypertension, and those things, high cholesterol. And you have this smoldering picture of low-grade diabetes, and we'll talk about the metabolic syndrome, but we have so many. As we age, we start to see in our 40s and 50s that the waist circumference starts to increase. We become, instead of lean and vertical, we become more horizontal, okay? And when that happens, we start to see cholesterol, triglycerides go up. We start to see that your good cholesterol goes down. And this is a setup for early heart attacks. So we've lost so many, especially Black men in their 40s and 50s, and we all hear about Black men that we've lost throughout the years, and a lot of this is just poor blood pressure control, low-grade diabetes, cholesterol profile that is really upside down, with a really bad good cholesterol, high triglycerides, poor diet, and as a result, heart attack and stroke ensue.
Let's get a little bit more specific, because I want the audience to understand what you mean by talking about good cholesterol and bad cholesterol and blood fats and things like that. Anybody want to give a little explanation of that, so our audience can understand what is good cholesterol, what is bad cholesterol, what do we mean by triglycerides, and what do they need to be, and things like that? Because I think a lot of people don't understand that, they may have a large amount of good cholesterol that may be protective as opposed to bad cholesterol. So anybody want to take a little few minutes to talk about good cholesterol, what does it mean, and what it is, and that type of thing? So anybody?
Yeah, when we look at the cholesterol profile, there's a traditional cholesterol profile where we have our total cholesterol. That's everything. That includes your good, your bad, your triglycerides. So we do look at that total cholesterol number, okay, which is comprised of all three of those variables. But we look, even more closely at your low density lipoprotein. So that's your LDL, your low density lipoprotein. And what we know about the LDL is that it's a bad actor. Okay. So the bad actor of LDL, it's atherogenic. Okay. So it damages the lining of the blood vessels. It infiltrates the blood vessel. It sticks to the arteries and begins to narrow the arteries. And we develop these unstable plaques inside of the blood vessels. And this is driven by hypertension. Everything we talk about, hypertension is a driving factor. But that LDL, so we do have goals for your LDL, and we have dietary changes that we make to lower your bad cholesterol, your lousy cholesterol, which is your LDL. But then too, there's your high density lipoprotein, which is your good cholesterol. And we talked about how that is beneficial. So having a high density lipoprotein, or good HDL, is protective. That's your protective cholesterol. Some say that it cleans out the plaque in the arteries. Your triglycerides, we tend to say that that's the fatty part of the blood. And when your triglycerides are elevated, typically that's because of a diet high in carbs, poorly controlled blood sugar, alcohol consumption. Those things are going to raise your triglycerides. And when your triglycerides are elevated, we very oftentimes see that your high density lipoprotein, your good cholesterol, is low. So that ratio is bad. Triglycerides, when they're elevated, can cause heart attacks as well. And then finally, a lot of us hear about the ratio. Say, well, what's your ratio? So the ratio looks at your total cholesterol compared to your high density lipoprotein, your good cholesterol. So we really want a good high HDL. So if your HDL is high, your ratio is going to be much lower. Okay, so if you have a elevated ratio, that means, for example, your total cholesterol is 200 and your HDL is 50. Your ratio is going to be 4-to-1. Okay, so a 4-to-1 ratio is not so good. Okay, what we want is a lower ratio. So you want more HDL, lower total cholesterol. And then finally, I just want to mention, once you get your cholesterol profile, so when you go see your doctor next week or tomorrow, you really want to request what Dr. Ford mentioned, was that lipoprotein A. Okay, lipoprotein A is a bad actor like LDL. It is atherogenic. It promotes bad and unstable plaque in the arteries. And we see patients who have an elevated lipoprotein A. These are the patients that have heart attacks in their 30s, have bypass surgery in their early 40s. As we looked at patients who have heart attacks, what we saw initially was that half the people who have heart attacks have good cholesterol or decent cholesterol. It's not so bad. So we began to look at other factors that play a role in heart attack and stroke. And lipoprotein A, get it one time, get it checked. And if that's elevated, your risk changes and your goals change in terms of what we should do with your LDL. So lipoprotein A, everyone should be screened for it. And there's the last is the ApoB and your high sensitivity CRP. So these are numbers that have gone beyond the typical old-fashioned cholesterol profile.
I think another thing that you mentioned, Dr. Wingfield, that is important, because I'm sure we could all attest, you get that patient, you tell them their cholesterol's high, and maybe there's other risk factors. So the indication for starting them on medication is there, but they say, you know what, I really don't want to go on medication because I just want to try to work it out myself. And the point that I've been trying to make to people in recent times has been, the longer you have this state of elevated cholesterol, the more damage that it's doing in your body now. So later on, you might not have the ability to bounce back from an event if an event was to occur.
And I think that's even more important what Dr. Wingfield said about the 10-year cardiovascular risk. So once you throw that out to the patients and they can see in black and white, no, you got a 20% risk of having a cardiovascular event in the next 10 years, when it should be down less than 7.5 or something like that. That makes them think about it. So now all of a sudden that's a concrete thing that they can see. And some people, I think that's one of the ways maybe convincing people that, hey, you need to take some medication.
So you brought up the subject of medication. That's something we're going to get into in a little bit, but I want to just say that I don't know what I didn't calculate it, Dr. Wimper, but I know I have a very high density lipoprotein. Mine is very high, but my total cholesterol is also is in, I don't know, over 280 or something like that. But my LDL and my triglycerides are low, so I guess my risk factors are way down. And I did have my arteries checked and they're clean, so I have to go through that. But folks, it means a lot, folks. I mean, we're not just throwing these numbers out there, these titles and these things out there because they're very, very important. But you have to understand. You might say, well, my cholesterol is high, but he told me I had good cholesterol. But okay, your good cholesterol does contribute to your overall cholesterol picture, but as Dr. Ford and Dr. Wingfield state so eloquently, your LDL-A is more important than anything else because that's elevated. Doesn't mean you got a high, your HDL is high, because if that bad boy is high, you in trouble. Okay, so go ahead, Dr. Wingfield. Seems like you wanted to ask something.
Yeah, and you really, again, you have to do that risk calculation and you have to act on it. If you see that your cholesterol is high, a lot of this, it's not always diet. Okay. Right. Family history plays a big role in how much cholesterol I make and you make. So your liver pumps out cholesterol. You need it for your hair, your skin. Your body needs cholesterol, but we only need so much of it. But if your body is pumping out so much LDL, it's going to have to be managed with good diet habits. But also medications. In a lot of cases, you talked about like familial hyperlipidemia or familial hypercholesterolemia, which is it's a genetic defect that causes significantly elevated cholesterol numbers. So if you have that condition, or if you have a family history of high cholesterol, it needs to be treated because this plaque is sticking to the arteries, and you don't have 6 months to wait, or a year to wait, or I won't start medication right now. I'm going to work on my diet. And then, we kind of lose you for the next 6 or 8 months. And then you come back and the cholesterol is even worse. All of this is that smoldering picture, and typically goes along with high glycemic levels or diabetes, blood pressure. And it's all fuel to the fire that can be prevented.
Yeah, you're so right, because I've seen so many times people say, well, the doctor told me I have high cholesterol, so I'm just going to watch my diet and blase, blase, blase. And I can tell you from personal experience that, I'm one of those people that, I do everything meticulous. I write everything down. I watch everything that goes in this little teeny body and comes out of this little teeny body. And for years, I thought I was doing the right thing, by watching my diet and restricting my cholesterol. My triglyceride and fat intake. And I still do that. But I want to tell folks that I still had to go on medication to get it to the right thing. Even though I had a elevated HDL, I still had enough of the LDL elevation that I needed to reverse that. And thank God I've reversed that now, so that I'm now just watching my diet. And I am very, very meticulous about watching what goes in. I mean, I know how much fats I'm going to take in a given day, because I write that down. My goal is to stay under this particular number. So, Dr. Plummer, I haven't heard you say much more about the cholesterol issues in women. How does that affect the pregnancy, and how does that affect blood flow and things like that in women?
Well, during pregnancy, we usually don't do any cholesterol medication, because cholesterol is the basis of all the steroid proteins they need for estrogen, the baby's going to need for progesterone. So generally, if they have elevated we don't even really bother even checking, cholesterol, unless they really have a history of hypercholesterolemia. But then we don't usually treat that, because the fetus is going to need the cholesterol. But after they deliver, they also will need that for, cholesterol for also breastfeeding. But also after that, they need to get tight control on their diet and on their cholesterol after delivery.
Suppose they were on medication before they come to see you. How do you manage that?
If they were usually taking Lipitor, we usually recommend that they usually stop taking Lipitor while they're pregnant until after they deliver, and then they can go back on the medication, just because they need cholesterol for that. And it's not really recommended that they take Lipitor while they're pregnant.
Okay. Okay. And we talked about medication. But let's get a little bit more specific here. In our community and communities of color, we usually on some medication. Oh, doc, I take a blue pill for my sugar. I take a white pill for my blood fats. I take this green pill for my blood pressure. So how is all this interrelated? Folks say, well, I stopped taking that medication because it didn't make me feel right. That's his medicine. That was that white pill. I guess it was the one I took for my blood fats. People don't understand the importance of medications and the need to manage your medications appropriately. So let's talk a little bit about that, guys. You got your Dr. Ford, you got your diabetic, Dr. Isabell, you got your hypertensive, and then, they all, somewhere along the line, they may develop atrial fibrillation. So let's talk about what happens to people when they stop taking the medication or they refuse to take the medication. Let's talk about that as a cardiovascular disease issue too. So anybody can just start with that little overview.
Stroke.
So when people don't take their medications properly, for example, the blood pressure medication, they can obviously have a stroke, a heart attack. The heart can get too enlarged where it doesn't get enough blood flow, put them at risk of abnormal, life-threatening arrhythmia. Also, if they don't take their diabetic medication, also can affect kidneys, and if you have bad kidneys, also can affect your heart more. It can also increase risk of arterial disease. You may have a small unknown heart attack that's weakening the heart, and your heart is a pump. And which other big thing of heart disease, you develop congestive heart failure. And that's because all these not taking your medications, and the heart is the pump that pumps the blood to all parts of your body, including the brain, the kidneys, everywhere, and where the oxygen, you need oxygen to live, and if you don't get those, and that affects your health. Some of the signs briefly of CHF, you may start feeling fatigue, shortness of breath. You may know your legs are swelling, you retain fluid, and then that can put even more strain, and where you can also have a massive heart attack or some other arrhythmias. So these are some of the important reasons why to take your medications.
Also, that there is something that's called peripartum cardiomyopathy that also happens when pregnant women, when they start to have heart failure, especially during pregnancy, and especially after you deliver, because the amount of demand that's on the heart during pregnancy, their plasma volume goes up about 50%. So that is a large amount of fluid that is also the heart is pumping. And after delivery, that blood flow is no longer going to the uterus, so it goes back into the intravascular space. And when you do that in a short period of time, it can overwhelm the heart that is weak to begin with. So, people that do happen to have congestive heart failure, or what we call cardiomyopathy, have to be very, very careful when they are pregnant.
So we talked about medications. We talked about diabetes can cause hypertension. Hypertension can cause heart disease. Heart disease can be affected by all kinds of things. We take medication for all three of them. Now, my concern is that right now we're seeing so much direct-to-consumer advertising on medication. Do you think those are a factor? Anybody think those are a factor in making some people don't want to take medications, because they give you this whole long list of, like, if you have this, ask your doctor before you start taking this medication. It can cause blah, 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 and run through a lot of side effects, but they always talk about, in some cases, death. And I think people hear that and they're kind of a little bit leery. So if I want to take that kind of approach to, like, talk about direct to consumer, and in itself, people go read up on things. A lot of people use Dr. Google these days to look up medications and things like that. So how do you think that impacts our ability to prevent heart disease in our community, or if it is any problem at all?
Well, I think one of the ways that I see it pretty regularly is, say I start you on a medication. Now, normally my practice is I will explain what the anticipated side effects would be from the most common, and then the things that are the least common. What does least common mean? 1 in a million, 1 in 100,000, whatever the number is, I give them that. But what happens a lot is they start taking the medication, they may speak to someone, see some information that makes them uncomfortable, and then they stop it. And you might have made the appointment for 3 months later. So now they walking around for 2 months on no blood pressure medicine.
Mm-hmm.
And the consequences don't care that you didn't feel comfortable with the explanation you got. And unfortunately, the consequences can be very, very real. So I see it happen quite a bit. This is where I try to make sure they use our patient portal so they could send a message, telehealth or telemedicine visits, because sometimes that may be more convenient just to go over side effect concern. So it is something that we have to deal with, and I try to be as transparent. And then also in my transparency, just let them know, well, if you don't take it, this is what might happen.
Yeah, you brought up another interesting point. Nowadays everybody's getting there. You have to have electronic medical records, but I think the patient participation is important, because I know at least my primary care doctor, I have a ability to go in and log in my blood pressures as many as I want to, and his nurse can track my blood pressure from home. It's called home blood pressure monitoring, but it's through electronic devices. The patient portal you talked about. So it's important that people, keep a track of their blood pressure. If you're not going to take your medication, at least check your blood pressure so your doctor know where you are, because as Dr. Phillips say, you walk around here and it may be too late. You might get to a point where you end up having some type of cardiac disease or renal disease because you didn't take your medication. So, but
you know what? One thing, I'm just going to jump in real quick, because that's the thing. It's about, when we talk about hypertension, it's the silent killer. It's the one that goes undetected. You don't feel it. You're not getting your eye exams. You ended up with hypertensive retinopathy. You're not being evaluated on a regular basis because you don't feel it. Now, if you're one who's getting headaches and nosebleeds and blurred vision, that means your blood pressure is through the roof. So by the time you feel the hypertension kick in, it's too late. But we have ways of detecting your blood pressure over a period of time. When you see your cardiologist and you get an ultrasound of your heart, you get an echocardiogram, we can make measurements of your heart muscle, and we start to see that heart muscle is thickening over time. That tells us that your blood pressure has been uncontrolled. The heart's a muscle, and if it's pumping against high pressure, it starts to thicken and it starts to stiffen, just like a weightlifter. Your kidneys, we start to see that your creatinine, your kidney numbers are elevated, right? If you're not getting blood work, you're not seeing your physician, slowly over time, your kidneys are getting worse and worse. The kidneys, the eyes, the brain, the heart, they can only withstand pressure being so high for so long. They start to fail. So these are these kind of quiet numbers that we can see that typically go undetected. Why do you have AFib? Well, because your blood pressure hasn't been controlled. You haven't been taking any medicine for your blood pressure. Why am I losing my vision? Because your blood pressure is uncontrolled. So hypertension finds its way into all of these medical conditions. And why did I have a stroke? Well, your blood pressure has been through the roof and you blew a blood vessel and you ended up with a stroke. So you really need to get routine eye exams. You need to get an EKG so we can determine if your heart is enlarging from hypertension. You need to get routine blood work to take a look at your kidney function over time. So these are all things that need to be done through over a period of time, not just, all of a sudden you're sick and then you're getting all this. And well, nobody ever told me that I had high blood pressure. So you got to get yourself checked out.
So once again, I'm hearing that we got to see our primary care physician. Go ahead, Dr. Phillips.
No, go ahead. Dr. Ford was about to go.
Well, I think what's important too, what we're saying is the home blood pressure monitoring.
Yes.
Right.
Mm-hmm.
We have ways now where you can check your pressure at home. And then if you see that it's elevated, then that's when you definitely need to contact your primary care physician or your cardiologist, whoever's monitoring you at that time. So it's not just one blood pressure if it goes up, but we're looking at what the trend is, right? So you want to definitely get a good blood pressure cuff. I think the Omron is the good one, as Dr. Wingfield mentioned the other day. That's a great one of the better ones. But still, even when you have it, you want to bring that blood pressure monitor into your physician's office so they can check to see whether it's working properly. But that's just one of the things I think that could be helpful to keep, monitoring your blood pressure to make sure that it stays under control.
In line with that, Dr. Ford, I think you get a lot of people that say, hey, I'm going to eat right. I'm going to take my whatever supplement, and that's going to get my blood pressure right. And in saying that, I'm not doubting that these individuals would do it. The one thing that they don't do is they don't check their blood pressure to make sure that the intervention is working, so that if the intervention is not working, then you can move on to what option B may be. But, that follow-up part, we're going to keep coming back to prevention. That's one of the unfortunates as far as it being something that we don't practice as much in our community. But I don't like talking about it like people don't want to go see the primary care doctor. There's a shortage, and a lot of times in the communities that we live, we don't always have primary care that's available to all of us in that community. So again, and that is in part due to lack of availability, but also people not being aware of how important having a primary care physician is.
Yeah, go ahead, Dr.
Oh no,
Yeah,
I was just going on. Oh, sorry about that. I was just going off of Dr. Phillips. Just the availability in the community for healthy food. It's a food desert in a lot of places to do healthy food. So what is available is a lot of processed food with has sodium nitrite and lots of sodium, because the American palate is really been trained to like a lot of sodium and also a lot of sweets. It's a very satisfying thing for us to have. And when you're taking in a lot of sodium and a lot of processed food, that also increases the hypertension, heart disease, also diabetes. So we also need to also get active in our communities and also in our politics also, to make sure that our representatives are representing our communities properly, that they can get access to good nutritious food.
And you bring up a good point there, because realistically speaking, it is far cheaper to buy unhealthy food than it is to buy healthy food. I mean, it's marketed so that this is a special, very good, healthy thing for you. But then you look at the price and compare it to say some sodium-laden chips or something over there. Well, I can get the chips a whole lot cheaper when I want a snack, then I get a healthier snack, or like whatever it is out there. It's just cost prohibitive for our people. Our people are not going to be able to go out and afford all the healthy foods that we want them to have, because the retailers price them so high, price them out of their pocket. So that's a good point. As a point I wanted to bring to you there. Somebody else had something to started to say.
Yes, there also may be, regarding taking medication, a social component to it. They may can't afford that co-payment, or they want to pay that bill, or not telling their doctor if they're having a side effect of that medication. Some don't want to disappoint their doctor, feel like they're going to disappoint your doctor, but you're not going to disappoint your doctor. Just like some people don't want to tell their teachers something if they're having trouble with some on a test or learning. So if we know that, we can do alternative. We can change the blood pressure med or the medication that may not give you the side effect, or find one that costs effective. Or there's programs out there that may pay for your medication. But if we don't know, it'll be hard sometimes to help you, or be aware, or just assume that. Not all doctors, but some assume that you're just not being compliant. But that's why you have to have a good rapport with your primary care physician. Also, I've seen, because I also do inpatient, where you think a patient, they're taking all their medications, but then you put them on it sometimes in the hospital, and their blood pressure can go too low, or it can affect, it could be too much, but because they didn't tell, well, doctor, I wasn't really taking that high dose or that higher dose in the outpatient. Or you tell your doctor you're taking the blood pressure medication. Oh, the blood pressure is high. Let me adjust it, and I raise the dose. And they assuming you were taking it not. So it can have long-term effects if you're not honest all the time or being open and having a good rapport with your primary physician or any doctor that is involved in your care.
I think when you talk about the uncomfortable side effects, Dr. Isabell, unfortunately in the men, one of the biggest concerns is impact on erectile ability. And, to just keep it 100, a man's ability to have an erection. And unfortunately, you get a lot of men that say, you know what, I'm not sure. And there are medications for blood pressure that have less of a side effect in that area, so we can adjust it, And the other part, as we talk about signs of potential cardiac disease, when you start having trouble with erections, that may not be just, I'm getting older. That may be something that means you need to go get your cardiac system checked out, because that sometimes is the first sign of a bigger problem.
Wow. I didn't think about that part of it. We talked a lot about a lot of things. Go ahead. Somebody had something they wanted to bring up. And we talked about a lot of things, and we all often talk about prevention in these webinars. The whole webinar is designed to have preventative health in our communities of color. But we also got to talk about, we got to stress that family history. You got to know your family history, because there are some cardiac illnesses that are genetically transmitted through family history. And sometimes you want to know those before you go get married, because you want to know if you're going to produce a child that may have a problem. Or sometimes you don't find out you have a problem with your heart until you've go and have some event happen on the field or something like your child. And you say, oh yeah, well, we do have a family history of that. And I forgot all about it. I forgot to tell my pediatrician about that. So family history is very, very important. I don't want to minimize that at all. And Dr. Isabell brought up the issue of the stigma. I know a lot of guys. I ain't taking no blood pressure medicine. I'm all buff. I don't need to take that kind of stuff like that. So we need to get that out of our thought process. We need to take our medication so we can stay healthy.
And you know what? To that point, a lot of it with the issues that we talk about, erectile dysfunction, it's the uncontrolled diabetes, it's the uncontrolled blood pressure. That's having a bigger impact on the ED as opposed to the medication or the tablet that you're taking, right? So that blood pressure and high sugar in the blood over time is affecting blood flow. We talk about ED, but we talk about blood flow to the extremities as well. So that's something we need to talk about as peripheral artery disease. But it's the other factors that will have a bigger impact on those side effects or those effects that we're talking about than the medication itself.
Good point. So, another area we get into is that people don't want to do some type of preventative stuff. And the biggest thing Dr. Phillips and I saw during the COVID, when we were doing our COVID task force, was people didn't want to get the vaccine. And, I know everybody doesn't want to get it, and that's their choice to make that. But, one of the things that we saw during the pandemic was heart disease. And that is not going away, because some people that develop COVID untreated, didn't take the vaccine or whatever, and develop COVID may develop long-term COVID. And part of long-term COVID is heart disease. And let's don't minimize that. Everybody talks about the brain fog and the neurological problems, but heart disease is a big part of it. And we know that some kids had a lot of problems with heart problems during that. We didn't talk about aneurysms tonight, but I just want to bring up the point that one of the things that we see in pediatrics is Kawasaki disease. And Kawasaki disease and MIS-C, multi-system inflammatory disease of children, was often confused when we first saw that. They thought that the MIS-C might be a manifestation of Kawasaki, and it's different. And I'm not going to get into the whole different points that I can talk to you about. I mean, Kawasaki has a lot of things that we see, but when you look at MIS-C, say for instance, your troponin is going to be way higher in a child with MIS-C than a child with Kawasaki's disease. People don't realize that. But one thing about Kawasaki disease is aneurysms of the heart. So, we need to talk about aneurysms, because aneurysms are another thing that tend to run in families. And if you have hypertension and diabetes, it might put some further risk factors on that. Any discussion on that real quick before, because we got about a few more minutes left, but I want to bring up every aspect of it so we have all of our audience know all about those things. Dr. Wingfield, you had something you wanted to say? Like you had something you wanted to say?
Yeah. You mentioned aneurysms. We should be screened if you're a smoker, if you have hypertension. But anyone over the age of 65, if you have any history of smoking, if you have a family history of aneurysms, you should be screened. Because we talked about in another webinar, we all know Tommy from Martin, and he passed away from a ruptured aneurysm. So those are things that we need to look at. You also should have your circulation checked. If you are diabetic over the age of 50, we should be looking at your circulation. We see the rates of amputation in the African American community is higher than any other community. And the impact of amputation is that if you look at it, once you have an amputation, your 1 year mortality is 20%. So 1 in 5, after you get that first amputation, 1 in 5 will be dead within a year. This is 20% mortality. This affects your entire quality of life, your access to further care. And at 5 years, it's 50% mortality. So yeah, they got to cut my toe off, or there's more to it than that. Okay. So these are really big offenders when it comes to the impact that it has on your lifestyle, your quality of life, healing process, infections, and peripheral artery disease is just the tip of the iceberg. Okay, because typically when you have problems with your circulation and you're getting leg ulcers and skin infections, the blood sugars are high, and that's driving it. You have poor circulation, you have high blood pressure. So all of these things result in peripheral artery disease and morbidity and mortality.
Let's not forget too that we talk about ischemia, poor blood flow. The one thing that cholesterol can do is block those coronary arteries, so we have ischemic heart disease as well. So people need to realize that they're at risk for heart attack, not only peripheral vascular disease, but heart attacks as well. So I want to bring that point out here. And there's other things that can cause heart attacks that are not necessarily related to cholesterol in young people doing some risky behaviors, but we won't talk about that so much here. Certain diseases, certain drugs out there. I think Dr. Isabell mentioned that earlier about certain drugs can cause increased cardiac problems. So we talked about a lot tonight. We talked about hypertension. I think that's a recurring theme I've heard tonight: hypertension, hypertensive cardiovascular disease, hypertensive cardiomyopathy. We talked about diabetes. We talked about diabetes affecting peripheral vascular disease, and we talked about it affecting the heart as well. We talked about diabetes and different things in pregnancy. We talked about how pregnant women, number one killer of women is heart disease. So we talked about a lot, but all these things come right back to our community. These are the things that we deal with on an everyday basis in communities of color. So we kind of running out of time, but I wanted just people to understand heart disease doesn't mean just related to the heart. Heart disease means a whole cardiovascular system, and we need to make sure we take care of that. We need to make sure we talk to our primary care doctors about it. And if not, you can end up seeing my good brother, Dr. Wingfield, because he can have to do some intervention on you if you don't take care of your heart. So I'd like to take this opportunity for each brother to just give them about their wrap-up talk. We'll start with you, Dr. Ford, because you had some very interesting things to say to us tonight. So go ahead and give us your recommendation, your final thoughts for tonight, please.
Well, thank you. I think, prevention is key. One of the things we talk about for hypertension is a low sodium diet, right? Or low sodium, high potassium diet. We talk about exercise, making sure that you're getting at least 150 minutes of exercise per week. Obviously, we definitely don't want people to smoke. We know smoking increases risk of cardiovascular disease. And those are some of the things that we can do just in general. So I'd just like to thank everyone for all the information that you guys put out today. I think it was very helpful for everyone. Thank you.
Thank you. Okay, Dr. Plummer, will you give us your closing remarks, please?
All right. It's great to be back with the brothers again. Got a lot of information today, gave a lot of good information today. Still just want everyone to know that women should still get their primary care evaluation yearly, just because, and not just only when they become pregnant, because there are a lot of underlying diseases that can't really be diagnosed until it's kind of late in pregnancy. So prevention is always a key. We always reiterate that constantly all the time. So please follow up with your primary care provider. And thank you.
Thank you, Dr. Plummer. Dr. Isabell, 95, give us your closing remarks.
Thank you. So as the other brothers said, prevention is the best regarding multiple medical problems, hypertension, diabetes, as well as lifestyle changes. If you drink, if you smoke, that also puts you at risk. Lastly, I'd like to talk briefly about aneurysm. What is the aneurysm? It's a dilation of the blood vessel because it's weakened. It could be in the chest or it could be in the abdomen. Sometimes you can present dizziness and back pain. I know brothers personally that have passed away from aneurysm. So closing, important, see your doctor, get examined, your routine physical exam. Thank you.
Thank you. Now we'll go to our cardiologist on board, 92. Dr. Wingfield, will you give us your closing remarks?
Thank you. This was excellent. There's so much to talk about in so little time. So what I would certainly close with, just to begin, because we didn't mention the signs and symptoms of stroke. So quickly, stroke is of the essence. Okay, when you have symptoms of stroke, you have essentially 4 hours to seek medical attention, so we can do an intervention to reverse the results or the impact of a stroke. So issues with your balance, loss of vision, slurred speech, headaches that are worse than you've ever felt before, issues with loss of vision. There's several symptoms that we really need to be aware of and take very seriously, so we can get urgent treatment for stroke. Just in terms of the closing remarks, I know we pressed for time. One always starts with getting a primary care physician. Make sure. Number two is knowing your numbers. You need those numbers so that you can calculate your cardiovascular risk. We should all be calculating our risk so that we know, what do we need to do? What type of changes do we make? When you put in your blood pressure, whether or not you take a medication or not, it's going to affect your overall risk over the next 10 years. So know your numbers, be familiar with it, get yourself a blood pressure cuff and calculate that. The number three is getting a coronary calcium score, which is a 3-minute CAT scan of your heart that's going to detect how much plaque, if any, is in the heart arteries. You get a score of 0. That tells you that there's no detectable hard plaque in the arteries. That's a great place to start. That is a normal score. Anything above a 0, there's work that needs to be done. So go out, get a calcium score, get a blood pressure cuff, know your numbers, and calculate your cardiovascular risk profile. So we really need to move the needle and start making some changes from diet, exercise, but also really taking control of our medical care and in our lives. Thanks.
Thank you so much, Dr. Wingfield. It's certainly been interesting to hear you. 88, our chairman, give us your closing remarks, and then we'll go ahead and close it out.
Well, I, again, just want to thank the brothers for their time and their expertise. Again, this message of prevention is something that we really feel very passionate about. And unfortunately, we've all seen individuals and circumstances develop that were more challenging because one did not head this issue off at the pass. So cardiac health, heart health, it is one of the most significant killers in our community, and we need to be proactive at keeping it under control. So again, it's been told to you, it's around that time of the year, you should be making your appointment for your annual physical. Get to know your numbers, get to know that 10-year cardiac survival rate so you can make adjustments and start to initiate those healthy lifestyle habits, eating right, exercising or being active on a regular basis, and following up with your doctor if it's been indicated. So thank you very much. And 78, thank you very much for being our moderator this evening, my brother.
My pleasure. So folks, I want to thank you all for coming out to do this. We also want to thank our brother Del Rico Gales, our district representative, for allowing us to do this. And last but certainly not least, we want to thank Brother Piercy, who does all the behind the scenes work. He's responsible for all the technical stuff you see and us being able to get out there to talk to you about it. We couldn't do this show without him. So thank you so much for all you do, Brother Piercy. And folks, you heard it all. See your primary care. Think about your heart health. And please donate blood. Until that time, we'll see you next month at the end of the month, the last Wednesday of every month for our health and wellness seminar. Thank you so much and have a good night.